Good morning, everyone. Today is October the 10th of 2022. I can't believe it. And I'm Robin Shapiro. I'm the board chair of HealthAdvocateX. And you have joined us for another community conversation, which is right now focused on COVID-19. And we're very pleased to be giving you a special edition of this on Indigenous People Day. And we have some special guests with us today. But before we go ahead and proceed, I'd like to just establish this meeting as a safe space. So that means that every voice will be heard and respected. And we enter the space with different lived experiences. And as such, we recognize the potential for unintentional harm. And we're committed to healing should that harm occur. We introduce this safe space statement and that alliteration as part of our diversity new statement and focus to make sure that we're just acknowledging everyone in the room, whether virtually or in person. So we're delighted that you could spend the time with us today. In the next hour, we're going to hear from Dr. Dale Reisner, who is Medical Director of OBGYN Quality and Safety at Swedish Health Services and a HealthAdvocateX board member. And we're delighted also to welcome Erica Mendez, who is an ambassador for the Native Action Network. She is a COVID-19 diversity, equity, and inclusion coordinator for Thurston Community Public Health and Social Services. And she also serves as an expediter for Banister Advisors, which is a health advocacy and lifespan company who you've heard before. Vanessa Laughlin is the founder, and she often joins us. So we're very lucky to have Erica today. She's a very busy lady on Indigenous Peoples Day, and she has a bunch of things to do. So she's going to be with us today until 11:40. So if you do have any questions for her after her presentation, go ahead and pop them into the chat. And I ask that you turn off your microphone until it's time for Q&A, and we'll hear first from Erica, who will also offer a land acknowledgement, and then we will get to some data with Dale Reisner. So with that, I'd like to turn it over to Erica. Welcome.
Thank you. Thank you, everyone, for being here today. And I appreciate you bringing up all my different titles there. Most importantly, I am also a Quinault Indian Nation woman, and I am a direct descendant of the Chehalis tribe. So the land acknowledgement for the location I'm at currently is on the Confederated Tribes of the Chehalis Reservation. It is one of the 29 federally recognized tribes in Washington state and the traditional land of the Coast Salish people. Currently, there are 573 federally recognized tribes that I would also like to give tribute to on today's IPT Day. So what I kind of wanted to kick off like chatting with folks about was my work through the county. So I've been a DEI coordinator for public health and social services. And when I came into the role as a BIPOC woman, I really wanted to create a bridge, not only to myself and my community that I already had on a personal level. I wanted to bring it for our public health and social services. So a lot of our outreach was based on focusing on, we focused a lot on addressing what folks needed within the community. Did we need to bring vaccination to them? Did we need to bring more information first? Did we need to connect with community leaders? And so that looked different for all different communities, but for the Indigenous population within my county, what we really needed was a little bit more outreach and more connection with the tribal health officers that were already working towards getting our community vaccinated and addressing our health disparities. Prior to my DEI position, I worked for my tribe specifically. I worked in IT so I set up our youth and our elders for online schooling, and then our elders so they could FaceTime their youth in their life. And then after that, I worked as a community contractor for at-home education. We were able to open up our community center to have lots of students come and learn from home. And also we were able to make sure they had good internet and food throughout the day. We were able to address a couple disparities that we saw within our own communities just by having contract workers like myself. And so once I moved over to the county, I knew that work was already being done. So it was about how can we not so much improve them, but encourage that work and be more of a teammate instead of going over and just like stop like taking over anything. It was more of a teammate instead of a takeover. So we were able to send out all of our different vaccine events that were happening to their IT departments. They were able to share it with all of their tribal members and folks that worked for the community. That was really important to us, just to also make sure that they knew that we were also a safe space and that that our work was encouraged through their health officers. We also talked a lot about multi-generational housing and what that would look like for folks. How could we get to our elders first and then go from there on the high risk rate. For our Latino community, we were able to do similar to what Washington State has as the caravan. We were able to do like a Vax van and take it to our local like Latino markets, our little pulguecita that we had in Lacey. So there was just a lot of different ways that we could do outreach. And so after we were able to focus on connecting with the community, we then showed up in the community. That was kind of how we chose to go about it. I was also able to connect with community health workers for migrants and refugees. That was also a big connect there. I'm also bilingual, but you know, it's not enough to have just one person in the space that's able to communicate with everyone. So having our local health advocates and our coalitions there was really important, just so that folks felt safe and they felt like they could be heard and that they were able to really receive like quality care. And I just know it was really helpful, especially with families and their children. It was, what does this look like for me? How is this? And then there's all the stigmas, and how do we address the stigmas within specific communities? So it was really about connecting with them, hearing them, and coming back with real information and videos. We were able to do videos, we were able to do pamphlets, one-on-one conversations with community leaders. So that's a lot of the work that I've done for my community, with my community. Also making sure, you know, all the goods are there. Everyone loves goodie bags, gift cards, community resource pamphlets. And with those, it was a lot of, our pamphlets were definitely focused on how do you focus on stress, or how do you cope with what is going on today. And that's been a pretty big deal. That's what I'll be chatting with a lot of our Native youth later on today, is how are we addressing our mental health? How are we addressing, like, what are you seeing within your home, and how is that affecting you? And how can you, within yourself, also deal with what other folks maybe might not be addressing, as far as
And Erica,
connecting with telehealth.
yeah. I was just going to ask and just put out there and thinking about, you know, folks that are tuning in from not just Washington State, but nationally. Are there any particular resources or strategies that you're recommending, especially dealing with mental health?
Yeah, so for myself, and this is what I've experienced personally, just because I also like going through all this work. It took a really big toll on me. And I am now like I would call myself a friend with my tribal doctor. I'm very fortunate in that I have a great relationship with her. But I would recommend telehealth, especially for folks that may be high risk, or even if you're feeling a little bit more anxious about how do I ask for help. It's a lot easier to ask for help within your own space. So if you have access to it, that's what I've been recommending, is a lot of telehealth. And then speaking with for tribal youth, I've recommended speaking to your tribal elders, finding like your auntie within the community.
We're just getting a
yeah.
little bit of feedback. I don't know if anybody else is hearing that from your audio. I don't know if you did anything, but there's like a echo.
Okay. Is that better now?
No, it's not.
No.
I'm
Okay.
wondering
I
if,
don't think I haven't actually touched anything, so
okay. I'm
I'm not
wondering
really
if we
sure.
can have you either log back in or take your video off so we can hear your audio more clearly.
Yeah, let me see. Is this better for you by any chance?
It isn't actually.
Okay.
So I'm
Let me
wondering.
go ahead and log back in then.
Okay. Yeah. Sorry to
I
break
might
the
use my
rhythm,
cell
but
phone.
yeah. Okay.
No, it's okay. It's okay. I'm on the res, so the IT or
Yeah.
anything here is really not loading well. So let me log off
Okay.
and log back in.
Okay.
Sorry.
Thanks. No problem. And while we're waiting for her to do that, Dale, if you can maybe pick up and just start maybe with some basic stats, if you can. Dale? Mhm.
Yeah, I was trying to stay off while she was speaking. So yeah, I can give a little bit of basic stats. In the United States, cases are over 96 million, and death rates over 1 million. I didn't pull up the global. It is a mess right now, and the way it's being reported is more country by country because it's so disparate, place by place. Sorry, there's a little noise in the background. From a vaccination perspective, we're doing really well with for 18 years and older, about 91% have had the full vaccination series. And it's 79% for 5 years old and over. So really quite good. Only about 35% have had one booster. So the boosting, I think, is going to be something for the fall. We can talk about this a little bit later. The combination of flu risk and COVID for fall, I think, is something that has people worried. The hospitalizations are decreasing. So the case numbers, I think, are really hard because people are testing at home and not all cases are being reported. And so when I look at what's really happening, I look at number of hospitalizations, and those have been coming down. We are seeing fewer people admitted within the Swedish system, and actually the Providence Puget Sound region. We have backed off on universal testing for people who are coming in for admissions, and we're testing based on symptoms or exposures. That's the first significant change in the testing. So looking at number of people who are hospitalized with infections is going to look a little bit different as well when we move away from universal testing and go back to screening. So this might be a good place to stop. Looks like Erica's back on.
Yes.
Let me stop
Yes.
and we'll see
Perfect.
if we can hear her. Yeah.
Great. Hi, Erica.
Yes. Can you? Hi. Sorry about that. Can you hear me better now?
Yeah, much better. Thank you.
Okay. Perfect. Yes, I just switched to my cell phone here. Yeah, the internet is not great where I'm at. I know we were chatting about mental health there. And
We
so outside of telehealth, so outside of telehealth and like kind of connecting with elders, which is what I've definitely encouraged for our youth to find like your local auntie. If it's not something you're comfortable chatting with your parents about, definitely find I within the Indigenous community, I would consider our aunties our health advocates because they've been through it, and a lot of them are creating a really safe space to chat about mental health and like potentials for like drug abuse and drug addiction. That's I know that's not only my experience, but it's the experience of most of our communities. And so if anyone else in the room can relate, I'm sure you have the auntie that you reach out to or like a mentor. And most of the time, most homes within Indigenous communities are also multi-generational homes. So that's why it's been great to say, hey, have you connected with your elders lately? Have you tried to learn something new? Have you tried reconnecting with your Indigenous identity and your Indigenous self? Just because a lot of our youth are so connected to social media and what are we seeing other folks doing? And a lot of there's so many different like health disparities that aren't seen on the media. So it's about addressing your health with what you have at hand, which has been our elders, our cultures, our actually a lot of health centers have been, just due to all the funding we were able to receive throughout COVID, improve and expand our health centers. So it's been great through our community. We've been able to take our youth to these new spaces and reintroduce them. And that's what also we've done with like our health officers and even our police officers within the community. It's been really big on like, how can we break down stigmas? How can we address these things and make our youth feel safe within our community? And it's a lot of reintroducing and introducing them to these spaces. And letting them know it's okay to feel unsafe. It's okay to feel these ways, but how can we address it with them? And how can you make sure you're letting an adult know that this is what you need? You need someone to hold your hand, to be in the space with you. And yeah, we've been, yeah, as far as myself being a contract worker, I spent a lot of time with our youth, just chatting about how they were really feeling about school and just how it was impacting them at home. And what they were seeing at home as a result of COVID-19. So yeah, that's kind of my experience and what I've seen has worked for our community.
I'm curious,
Um,
because a lot of folks that are in the health advocate community who are likely tuning in to this call are probably not Indigenous themselves, but probably would be interested in being supportive of the Indigenous community. And I'm just wondering if you have any suggestions for how health advocates that do that either professionally or have an interest in that could be more supportive nationally and in their communities.
um, yeah, yeah, absolutely. So within, I want to say most tribal communities, we will have like general council members that have more of a closer connection with our tribal youth. So, I mean, doing outreach to general council members to then see either if they have specific outreach set up, either through their community centers, their youth centers. The Chehalis tribe has a youth center, and we have mental health advocates that come in and they have like a fun Friday with them every so often. And they do like coloring books and like workshops. I know recently they've done like a notebook and someone like brought in their goats so they could like it was like goat therapy or like kind of
Wow.
like goat yoga, like the hot yoga with goats. So they brought in their goats and notebook. So it was really cool to like mix it up for like these
Yeah.
all these youth. So just find a way to like make it fun
Yeah.
and find your local community center. And a lot of them will open up an hour or two a day that you can come in and do like a small workshop. You can bring something fun, like how it's to raise spirits. So that's what I would recommend. Or connecting with health directors. I know that when I was on my journey looking for counseling, I was able to ask my doctor within my community clinic, and she had a couple lined up that have previously worked with Indigenous folks. So they were able to really create a safe space for me. And I know a lot of my peers that are also going through the same have been looking for folks that either have experience or are really open to creating safe spaces. So yeah, something as small as like a safe space acknowledgement can go a long way. Just knowing that our bodies are safe in that space and our point of views are safe. It's about saying what might make folks uncomfortable. For a health advocate, may be uncomfortable to say the first few times, but for someone listening to it, it shows us that you care. enough to either make yourself a little uncomfortable, a little vulnerable. So yeah, I hope that answers your question there.
Yeah, I think so, because I think that people on the call probably want to understand how to contribute to positively to various different communities. And I think as advocates, in the community and people who are supportive of that, we're trying to find tools and opportunities to contribute positively. So I'll go ahead and put in the chat the safe space statement that anyone on the calls, feel free to use. We've been doing a lot of our own work on diversity, equity, inclusion, and access. We call it IDEA. And that's been, we just released a statement. And so we're doing a lot of exploration to try to support communities and learn and do better in terms of supporting all people. So we really appreciate you coming, Erica. And I know you're going to stay on the line for a little while and if you have any questions for Erica, go ahead and put them in the chat, and then we'll go ahead and toss it back over to Dale. If you're there.
I am.
Okay.
Okay, so this is actually great because those of you who know me, I have called out the race and ethnicity disparities in the COVID cases, the vaccination rates, and so on. One of the things I want to highlight, and Erica may actually know details better than I on this, but if we look at the vaccine data, so Erica, when you were getting signed back on, I was talking about vaccinations in the US for 18 years and older being as high as 91%. And we look at the vaccination rate by well, first of all, maybe before even the vaccinations, let me finish up the cases by race. So Hispanic, the cases were 25%, the death rate about 17%. For Alaska Native and American Indian, we have 1% cases by rate and 1.1% death rate. For Black in this country, 12% is the case rate and 13% is the death rate. And for Caucasians or white, 53% cases and 63% deaths. Now, the higher death rate in the Caucasian population is really based on age. And many of the younger people who got COVID were white, of course, but also many of the mixed race and specifically designated races were not as high volume as those nursing home infections that started with really high death rates. So just to make that clear, the vaccination rates follow suit. And by the way, those percentages are pretty close to the percentage in the population. The number of cases per subset, and I don't talk about Asian too much because Asians actually have done well with this and have a high vaccination rate. But the number of cases now for new cases is going to correlate much more strongly with race and ethnicity because we've had fewer people take up the vaccinations in some of the most vulnerable populations. And it speaks really to what Erica was saying about people's past experiences and comfort and trust levels with the traditional US healthcare. When you look at the Hispanic population for vaccination in the last couple of weeks, so these are currently people, the Hispanic population is below the rate that they are in the community, which is overall about 20%. And remember, I mentioned their cases initially were about 25%, really because they had the other population of largest number that was getting exposed, as so many of them were essential workers and also multi-family dwellings. And then in the American Indian Alaska Native population, the vaccination rate has increased. And part of that is some very, very targeted, specific work done by Native healthcare workers within different tribal healthcare systems to get over some of the concerns that people have about, is the vaccine safe, and, not trusting or the distance that you have to go to get to a healthcare clinic if you are not stocking on the reservation and you live there, or in the territories that have been, I don't even know the right word, Eric. There's no good word for the territories that are inhabited by Native Americans who owned that land in the first place, and it was taken from them. So I don't have a great word for that, that can respect history and can show support for the Indigenous peoples of this country, of Canada, where I was born, and the wrongs that were done. So I'll just put it that way. But I think it really shows that one of the focuses for advocates is if you are white and you're trying to advocate for somebody who is not, if you can get someone else they trust in a better way, whether it's a family member, the aunties that Erica was talking about, in my world, it's doulas, but doulas can serve in non-pregnancy situations as well. And if you can have someone of color who can sort of be a translator for the patient with what you are trying to do when you interface as an advocate, I think your satisfaction will be greater and your success will be greater. So I just wanted to call that out with the differences in the vaccination rates, because we know right now in the African American and Black population, vaccination rates are lower than the percentage of the population. And we haven't had as much of that very focused work by people who look like the people of that community. And that's where the biggest impact is. But it doesn't mean there isn't a role for those of us that have light skin. So Erica, do you have any thoughts, any comments you wanted to add with that part of the discussion?
I don't think I have too much to add there. I feel like you've covered all the bases really well and in a super respectful way. So thank you for that. But yeah, I definitely think that I've seen it within like I can really only speak for like Thurston County and then my
Sure.
local counties that I'm connected with their tribal health departments. But yeah, just making sure that even our contract tracers are folks within the community or health workers that have been within our community for a long time. I know I can give a huge shout out to Chehalis tribe. Our health director happens to be my grandma's best friend. So she is really well known throughout the community. She speaks at our funerals. She's present. And so she is also a white woman. So she has come into our space and she has created such a safe space, and folks can really go to her. And a lot of our doctors, none of them are actually Native folks, but they show up in ways that I've never seen throughout our like local county. It's really only in the tribe that you can see your doctors coming to your funerals, to our homes, to like showing up for telehealth at hours that work for us, just because a lot of folks, we have to also talk about what folks can't take off that time from work. So working around those hours has been really important to our community. So yeah, there's definitely a space there, but it's about showing up and having good intentions and asking folks too, like if I'm in this space, what should I be wearing? What should I be saying? What are longhouse rules? Asking things like being open to asking questions and being corrected. So, but yeah, I don't think I have, I think as far as your stats that you've been reading, I have pretty much similar stuff. if anything, just maybe at like a smaller portion of it.
Mhm.
So yeah, I have, that's all I have.
Yeah. Yeah. I think if we work with everyone we encounter with humility, that's a place to start. And asking questions, being curious in a respectful way, I think really gets all of us further along, no matter who clients might be. And we will, in the background, be working on trying to provide scholarships for people who want to go into healthcare, whether that's nursing or physicians or physician assistants or anybody else in an affiliated healthcare position, to not only help people that are interested in doing those things as a career, but also to help the patient population that looks like them, have caregivers that look like them. And as we do all of this together, we'll get to the better outcomes, whether it's COVID or whether it's, almost any other healthcare condition where there are disparities. I think that the other comments I was going to make have to do with just COVID in general. If you haven't had it, you may have and didn't know it. If you haven't had it, you'll probably get it. It's everywhere. We're still pandemic based on the total number of cases per day. In the US, there's about trying to see I didn't write down the number of cases per day, but hospitalizations per day is about 3,000. So, those are the more severe cases. So there still are people that are getting sick. The vaccinations definitely are protective, even if it doesn't stop you from getting COVID. The symptoms are generally milder. You have much lower chance of being admitted to a hospital, and even greater reduction in risk for ICU admission or death. So we still need to think and talk vaccinations. If you're a candidate for the bivalent vaccinations that are out now, I would strongly encourage that you take that. You can do it at the same time as flu vaccination. And then, as I mentioned briefly at the beginning, flu season, we've not had a flu season in the last 2 years because people have been, on the whole, careful about masking and social distancing and staying away from large gatherings. And we are very concerned about a bad flu season this year. Bad meaning hospital admissions and deaths. So if you happen to be working with someone who has a chronic health condition, autoimmune disorder, chronic hypertension, diabetes, particularly not well controlled, obesity, and I know obesity is an area where we also have biases, and yet there are some healthcare concerns associated with obesity. Obesity seems to be a little bit of a chronic inflammation state in our bodies as we have additional adipose tissues. So all of those things contribute to our risk, not only for getting sick, but for being sicker if we catch something. So any even gentle reminders for mask wearing and so on will help your client and help yourself from getting sick.
I was just going to ask about the masking because it feels to me, and I'd be curious to hear from others who are on the call, it feels to me like, people are not even thinking about masking anymore. I was just talking to a friend yesterday who he is a NOVID. Have you heard of this? A NOVID? No COVID. I had not heard that before.
Whatever.
And he was like, I don't even carry my mask around anymore. So how important is that? And Gazelle just put in the chat I've heard people say that we've reached herd immunity. Have we done that? No.
We really haven't, because of the rapid new variants that are getting formed. The bivalent will probably help a little bit because it's really targeting some of the Omicron spikes, and so will probably be more effective. The wild virus, if you get it on top of being vaccinated, will undoubtedly add to your body's ability to respond. But we're probably gonna be like the common cold. So we will probably always need to do vaccinations if we want to stay as protected as possible. And it will be around, and you can get the cold any time of the year, and I'm afraid it's going to be kind of like that. It's not going
Like
to be
flu, like pneumonia,
flu
like
is
shingles,
really,
like all that, or
no. Well, shingles is a different animal, because shingles is your prior exposure
right.
to the virus, and it never leaves your system. So we don't think that the virus sets up home forever. We think it comes and goes. But because it has very rapid mutations, and because we have very global community in the world with travel and so on, that all it takes is somebody coming with a new variant from another country for us to have a new swarm of infections. So it'll be coming and going, and yet our ability to keep it at bay personally with our immune system will be better based on past exposures, either wild virus or the vaccinations and the boosters that we get. So far less risk. I mean, it'll be probably more like flu than anything else, although right now it's not clear that it's going to settle into any season because of the frequent mutations, and the fact that it has lasted and we've had big storms in the summer as when people are more outdoors. The more outdoors you get, I mean, that's the only thing that's helped us with flu, is that because it's not as easy to transmit, when people start doing outdoor things, gatherings and so on, it's not around in very large amounts. And so it swarms in the fall and winter when we get back to indoors, schools, all that kind of stuff. And we may get to that with this, but it's not clear.
Before I ask my next question, and I know that Erica has to leave us because she has two other events today. So I just wanted to say thank you to Erica for spending some of her day with us and for helping us understand your experience and also how we might be supporting and contributing to the Indigenous community. So any last thoughts before you have to leave us, Erica?
I just want to thank you all for having me in this space, and for definitely coming in with some great questions. Just some last thoughts are definitely, as a health advocate, it's okay, I would say, to be uncomfortable while working with folks of color, or folks within the BIPOC community. It definitely, I've seen folks come through the other side, and now they're some of our best health advocates within the community. Myself being one of them, I definitely came in working with Banister, I think has definitely set up a great space for me to learn. And so when I do work with I feel like I am more of a youth advocate for my elders that either can't drive themselves or maybe need a little bit more assistance. Just being okay, being uncomfortable for a little while, I think has been great for myself and other folks that I've seen that are now pillars within our community and our health community.
And
so thank you again. And if anyone has any additional questions, I'm happily available on LinkedIn. You can just type in my name and then like one of the many things I work for, and it should show up. And I'm happy to answer questions or set up one-on-one time.
Sounds good. And we know that we can also connect with you through Banister Advisors. So we will go ahead and do that. And we wish you a great day. And thank you so
Yeah.
much for sharing your wisdom and your perspective. We really appreciate that. And while Erica is
Awesome.
leaving
Thank you so
us,
much. It was great seeing you all.
Yeah.
okay, bye-bye. And I want to get back to some of what we were talking with Dale about, and also put in there that Annie Jacobson shares that she had a client with vocal cord surgery in UC Irvine 2 weeks ago and no pre-procedure COVID because of vaccination. So I'm really curious about if there will be data and better understanding of if vaccination is protective against long COVID, like does it boost your chance of having less of a chance of getting long COVID?
The preliminary data suggests that that's true. How much of a decrease, I don't think we know. And I do think that when we are looking at vaccine hesitancy,
Mhm.
that is something that's worth mentioning, because many people are not worried about getting, especially if you're young, right? Like, okay, so it's like a cold, I'll be fine. But
Right.
the long COVID is something that for people that are paying attention, folks really want to avoid, and appropriately so. We're going to learn more about long COVID over time as well. The numbers for long COVID are all over the board. And if you look at the definitions, they are all over the board. And that's part of the problem. So we know that this virus takes a toll and that it takes a while to get rid of. So I personally would love to see that we settle on a different definition of something like, I don't know, 4 months, 6 months. If you're still symptomatic, then you may have long COVID, because 2 to 3 months seems like that is not out of range for many people, either who got super sick or who had fairly mild disease and had some trail. So for instance, cough. I hear lots of people say I coughed for a month and a half afterwards, even though I wasn't that sick. And I don't think it's right to call that long COVID. Yeah, most of our viruses go away quicker than that. But the long COVID that has such a huge impact on people's lives, I think we need to look at and come up with some national or worldwide definitions that make a little bit more sense. I'm not the person to do it, but it just feels like it, outside of maybe 3 months, I don't know, that we talk about it and then start looking at, well, who has it and how many of those will resolve, because some people are resolving a year out. And there is a little bit of data. I know we've talked about this on this platform before and in other venues, that vaccination may actually decrease the persistence of long COVID for those that have that diagnosis. It can, in a smaller percentage, probably exacerbate symptoms, and for most, not make a difference if you've had COVID before and you have long COVID. But there were more people that responded by decreasing their symptoms or having it go away after vaccination than with exacerbations.
So you have to also
Yep.
give us, sorry to cut you off, but I really want to make sure that we cover Paxlovid versus the infusion if you get COVID. So I'm a Novid. I've never yet had COVID. I'm sure I'll get it sometime or another.
Maybe you've had it and you just weren't testing. Were you testing twice a week?
No, I was not. You're right.
Yeah.
You're right.
Yeah.
So, but I was joking around with someone and he was like, well, you'll just call your doctor up and get Paxlovid. And I was like, I know, but I've heard some things about that I'm not quite sure about that. So could you kind of give us an update about?
So you call your doctor up for Paxlovid if you are high risk or if you have what are severe, leading into severe symptoms. So if you've got persistent stuff going on, it only works within 5 days of diagnosis. So it's
Right.
going to pick a very small subset of people who choose to take it. Age is one thing, but it's more even age plus if you have, chronic medical condition that where the best results are.
Like if you have an underlying crummy immune system, for instance.
Yeah, if you've got lupus, if you've got Crohn's, if you've got, any kind of a chronic condition, certainly diabetes and hypertension and other cardiac conditions for sure. People do way better. The symptoms are dramatically decreased within usually 24 hours of taking the first doses.
But then what about the rebound?
Well, and what about the rebound is a great question, because there is rebound with a natural virus as well.
Oh, really? I didn't know that.
Yes.
Oh.
And we don't have good enough numbers to compare. So we'll be getting better data. The original data suggested, I don't know, less than 5%. Now, as Paxlovid is being utilized more, the last thing I saw was, I don't know, 7-8%. It's probably closer to 20%, but that means 80% of people won't have the rebound.
Right.
And then what you need to do is have that group of people that were just asymptomatic, so that kind of moderate range risk, and compare it to them to know what the relative risk is to have rebound with it. The rebound symptoms are milder. I've not seen any report where they were worse, and relatively short-lived. But I think you have to weigh, whether your risk from the virus itself is worse than the medication. It has a very nasty metallic taste, is how people have described it. And, you take it twice a day for 5 days. So it's a short thing. There may be some upcoming discussion about whether for high risk, really high risk people, or to avoid rebound, would you take it for an additional 5 days?
Oh, interesting.
But that's not been recommended at this time.
And what about the intravenous, the first intravenous product that came out in terms of when you were first diagnosed with COVID? Is that still something that people can get or should consider?
All of that is pretty much being reserved unless somebody knows of a unique outpatient situation for hospitalized patients.
Okay.
So there's not, to my knowledge,
if you have severe symptoms, that's
where you would be admitted. Yeah, not typically not when going to an ICU, but admitted for monitoring for your oxygen level or for a little bit of nasal oxygen or something like that. So there's nothing that I know of right now that's being done as an outpatient infusion since the Paxlovid, and there's another one that's around too that I haven't seen much data on since those came out.
So I'm curious too about if there is any data of people getting multiple COVID infections with and without vaccination and boosters, and just kind of like, because I'm assuming the data is going to get a little muddy, right? As we have certain people who get vaccinations, then fall off and don't, or didn't get vaccinations, got COVID, then got vaccinations later. Do we have an emerging picture on any of that?
I don't think we do. What is clear is that you can definitely get COVID more than once. And for some people, they can be in a pretty short proximity. That tends to be unvaccinated people, right?
Okay. Yeah.
But you can still get it for sure with a vaccination. And like I said, the the data supports that those infections in vaccinated folks are less severe. And you can still get it after the wild virus. The wild virus is not protecting you any better than the vaccination, and actually maybe wears off quicker. So I think that is there, there's a bunch of sort of think tank articles that are coming out about, how many times can any one person get COVID? And it also speaks to who gets COVID at all, right? So you think you're a novid, and you may be, and so what is it about you who's not getting it? So I got COVID. I think I shared with people on this meeting that I thought I had it at the very beginning before testing, but I'm fully vaccinated and boosted, and got COVID coming from a meeting where we didn't wear masks. And we were a bunch of friends that hadn't seen each other for 2 years. So we were hugging.
Yeah.
And of my family who was there with me, my son, who has the greatest exposure to me, my one son got it, very, very mild. He'd been vaccinated, he'd been boosted shortly before a trip. And I don't know if that has anything to do with it. He's obviously much younger than me. I was pretty sick. And my other 4 adults and the baby did not get it, even though we were all in the same spaces. So who knows why that is? I mean, probably my youngest got, more exposure being in the same house with me, but, we were sick quickly after the meeting. So you just don't know. Somebody else that was at the meeting who got it, my younger, mild symptoms, and her husband was there at the meeting with her, and they lived together, and she didn't know till days after we returned. He never got it. So yeah, who knows?
And I'm also curious, they had found, like with HIV/AIDS, for instance, that certain people had some kind of natural immunity, and after multiple exposure. And I'm just wondering if we'll be seeing that anytime soon, or if it will take a much longer period of time to understand that.
Yeah, I think that's the thing we don't know, because not everybody gets symptomatic. So you don't know, you didn't get sick because you've already been exposed, and your body says, hey, I'm not having anything to do with this virus. So that could be the combination of a smaller dose exposure. You see these big weddings and funerals and things where there's, big spreader events.
Yeah.
But not everybody gets sick being in the same space and place. So, excuse me. So I think that remains to be seen. I don't know if we'll ever know that one for sure. Yeah.
Yeah. So, so we have a few minutes left here, and I know I've been like peppering you with questions. So I want to make sure that if anybody on the line has questions for Dale, that you're able to jump in here. Sorry, I've been hogging up all the space here.
Or additional knowledge and thoughts, because we have a lot of smart people on this call. So
yeah, exactly. Lori Levinson had asked a little bit earlier if there's much data on how well the bivalent vaccine will protect against breakthrough infections. I know you talked a bit about that before, but maybe you can give us a little deeper dive on that.
Yeah, I think we'll know a little bit more as we get more people actually in the community having it. It should work better. It definitely should work better and have less breakthrough because of the Omicron specific component that's in it. But
and I know that next month in November, we'll be talking about COVID and the holidays and what the holiday season will look like. We'll be a little bit further into what fall is going to be looking like. And we also will be having a speaker talking about financial implications and financial bills and finances related to health and healthcare. So that's something you can be looking forward to for next month. I hope you all can join us. I'm going to look up the date here. It's the second Monday of the month, so it'll be November 14th. So that'll be a good time to get into what's happening with the holidays. But in the remaining 5 minutes that we have, Dale, is there anything kind of top in mind, main talking points that you want to leave with the advocate community here?
I think that really poignant to hear from Erica today on Indigenous Peoples Day. And her comments about putting yourself out there, being uncomfortable, I think are really key to that kind of work, and to work that we do in the settings we are in most of the time. So you may not have encounters with the Black or Indigenous people on a regular basis, but understanding how different their perspective is. We haven't talked about this on this venue, but there's the approach to interacting with anyone of trauma-informed care, where you can't tell. It's like you can't judge the book by its cover, right? You gotta get in, you gotta explore, you gotta see what's written on the pages. And we don't know what everybody's experience is just looking at them. You can see, I can remember this as a kid, seeing people thinking, oh, I wish I looked like that. I wish I was that smart. I wish. And it turns out that some of those people weren't what I thought they were. They didn't have the lives that I was, had built in my head from observing, and that I've had a richer life than they have, or that they're even still around. So, you really don't know, even people that you really don't know all those things about them and where their vulnerabilities are. So I think that fits to all of the work that an advocate does. You can get to know somebody a little bit, and then you don't really realize, some prior trauma or fear that they have with healthcare encounters, that they may not have verbalized. They might have told you they had a bad experience and given you some data, but it may not strike you that could be generations long fear. So.
Yeah, really good point. And I think the perfect way to end this call today. Listen, we appreciate everybody who's logged in today to talk with us and, provide feedback. And we hope that you'll join us next month on November 14th. And as always, we are so grateful to our speakers, to Erica, to Dale. Dale, you're amazing. And you might have seen our newsletter. People, Dale's actually retiring. The big R job.
Yeah,
the big
exciting.
RR is happening. And so congratulations on an amazing career. And, we're so grateful for you being part of this community and a leader in this community and leading our calls for 2 plus years now. So thank you so much. And we look forward to seeing you guys next month. Take care. Bye, Dale.
Yeah. Bye, guys. Have a great day.
Have a great day.